It's already 3 p.m. If Dr. Eugene would like to start, can start now.
Very good evening to everyone in attendance. My name is Eugene. I'm a physician from Hospital Taiping. So welcome to the month of rheumatology in December. As we know, this is our second week of the month, and our topic today will be titled Scleroderma, which will be delivered by Dr. Wong Ping Su, who is currently based in Hospital Sultan Ismail, Johor Bahru. It gives me great pleasure today to introduce our chairperson for today, Dr. Teh Cheng Leh. Dr. Teh Cheng Leh graduated from University Kebangsaan, Malaysia, and subsequently completed her membership of the Royal College of Physicians in the year 2001. She subsequently pursued her rheumatology subspecialty training in Tan Tock Seng Hospital in Singapore, and also at the Prince Alfred Hospital in Perth. Upon returning to Malaysia, she started the rheumatology unit in Sarawak General Hospital back in the year 2006, and currently is the head of the rheumatology unit in Sarawak General Hospital. She has very keen interest in research and has published very widely, both in local and also in international journals. So with that, Dr. Teh, I would like to invite you to share the session and also to introduce our speaker.
Thank you, Dr. Koh, for the kind introduction. It's my great pleasure today to introduce Dr. Wong Ping Su, the speaker for the rheumatology topic today, titled Scleroderma. Dr. Wong Ping Su is currently the head of Department of Medicine and Rheumatologist based in Hospital Sultan Ismail, Johor Bahru. She obtained her MD in 2008 and further completed her MRCP in 2014 and completed her rheumatology fellowship training in 2021. Without further ado, I invite Dr. Wong Ping Su to give her talk on scleroderma.
Good evening, everyone. Thank you, Dr. Teh, for the introductions, and I would like to also thank the College of Physicians for giving me the opportunity today to share with you how we actually manage the patients with scleroderma in rheumatology clinic. So I have no disclosure for this lecture, and this will be my outline of presentations. So my presentation will include introductions on systemic sclerosis, the epidemiology, of course, the different subtypes of disease spectrum is also important, and we go with the clinical classification criteria. And I'll probably discuss with you a bit on the concept of RADOS, which is also what we call as a very early disease onset of systemic sclerosis. Furthermore, it will be a mortality and morbidity overview. And lastly, I will be talking about the vasculopathy in scleroderma using the UK Scleroderma Study Group recommended guideline. So systemic sclerosis is known to be described as a presence of thickened or hardened skins. Is a complex connective tissue disease where there is presence of inflammations, vasculopathy, and sequential fibrosis in multiple organ and system itself. So it had been recognized many decades ago, but it is introduced as a concept in 1945. So let me share with you the stages of skin disease and why is it important, because you might be actually able to diagnose the patient earlier. We early refer to us during if you encounter these kind of patients. So mainly the stage of skin disease is actually divided into 3 stages. The first stage will be idiomyther phase, and you look at the picture on your screen, it should be on your right side. So that is an idiomyters during a skin assessment. So this group of patients, they will present to you telling you that they felt that the fingers is actually tight, they are puffy, they are swollen, and then subsequently they told you it might actually go to other parts of the body, which can include the face, the body, and forearm, as well as the upper leg. And this can present in 95% of the patient with early systemic sclerosis. The second phase is called indelitic phase, which is a collagen deposition in the dermis. And in patients with diffuse systemic sclerosis, these tend to be very rapid progressive over several months, and the patient can present to you with intense itchiness itself. And the last phase of skin disease stage is the atrophic phase, where the inflammations and infiltration has been stabilized. The skin has become more softer, but it is also tended to adhere to underlying subcutaneous tissue that you can see on this picture on the right side of the screen. So come to the epidemiology of systemic sclerosis, right? So this 2021 systemic review showed that the prevalence of systemic sclerosis is around 17.6 per 100,000 persons per year, and the incidence rate is at 1.5 per 100,000 per year. These are tentatively lower compared to other connective tissue disease like SLE and rheumatoid arthritis. Unfortunately, in Asian countries, it is low, but I'm not sure because probably we not screened enough, or maybe the patient presents we didn't recognize. So it should be in the future, we might have to see that whether any registry will be actually helpful for us to see this group of patients when they attend to you in the clinical practice. So systemic sclerosis can occur in any age, but it has high prevalence in patients aged 30 to 50 years old. And as of other connective tissue disease, female has higher prevalence compared to the male, which is about 4.5 to 1 ratio. And in USA, black has higher prevalence compared to the white populations. So looking at this chart, it also concludes that the prevalence of scleroderma is lower in Asian populations. And you can see that in this cohort, the one that actually share or reviewed in this review in South Korean population, Taiwanese and Japan. It is the same as the incidence rate in Asian, that is less study and there is also lesser incidence reported. Come to the pathogenesis of connective tissue or systemic sclerosis. Same as other connective tissue disease, it will be some genetic susceptibility where about 18 loci has been studied, and we have environmental factor including temperature, chemical infection, and others including breast implant, hormonal emotion, neoplasm, as well as vaccinations. With this triggering factor, they can actually trigger the immune system activations, subsequently inflammation, vasculopathy, and end up with the collagen depositions and tissue fibrosis. So often I use this simple diagram to tell my patients why, when they keep on asking me, why do I have that? And is this disease inherited? I'll use this simple chart to tell them that is a genetic and environmental susceptibility. So come to a more interesting part to show you the histopathology of systemic sclerosis in different organ and system. So the picture on the left side is actually a skin deposition on the light microscopic examinations. So on the first picture is the histopathology of patient with lupus, where comparative to the patients with systemic sclerosis, you can see that there is a dense collagen deposition in the dermis. And in fluorescent microscopic examination, there is lack of immunoglobulin G depositions comparative to patient with lupus. So the same pathogenesis has been proven in the histology of the lungs of the patient with systemic sclerosis, as well as the renal disease in patient in this group of disease. But in kidney presentations, the histopathology has showed that there is also fibrinoid necrosis and fibrin trauma in the arterioles. So I'm going to show you in this table on the odd ratios of the occupational and environmental exposure in patients with systemic sclerosis. So the meta-analysis has showed that patients or personnel who have silica exposure had odd ratio of developed systemic sclerosis at the range of around 2.81, and solvent exposure of 2, breast implant of 1.68, and pesticide exposure is about 1. And those that we were probably asking previously, can hair dye be one of the risk factor as well? This review showed that the data has not sufficient enough to prove that just yet. So the next part of my presentation will be the subtype and also the classification of scleroderma. So the first subtype will be localized scleroderma. So this disease is confined to the skin and subcutaneous tissue without the internal organ involvement. Example of this subtype are including morphea, linear scleroderma, as well as foot dysery. second subtype more commonly seen in rheumatology clinic are systemic sclerosis, which is a more complex diseases. It involves not only the skin but multiple internal organs. So in this subtype, there is two groups of manifestation. So the first group will be limited systemic sclerosis. It occurs in around 66% of this second subtype. So the patient often have a skin involvement involving distal to the elbow and knee joint. They have longer duration of Raynaud phenomena. They have late presentation of pulmonary arterial hypertension. And this group of patients have higher prevalence on the positivity of anti-centromere antibody compared to the rest of the antibody. The second group are the one that probably everyone are more familiar with, which is a diffuse systemic sclerosis. It is present in about 1/3 of patients with systemic sclerosis. So in this patient, they have received skin involvement, which is proximal to the elbow and the knee, and they actually present more rapid involvement. It can go until the trunk, face, and in the abdomen as well. And these patients has more lung manifestation. They can come with a renal crisis. They can come with myocardial manifestations, and they have a higher prevalence to have anti-topoisomerase antibody positive, which is also called anti-SCL17. So this chart actually just summarizes what I explained to you in the previous slide. So in patients with diffuse cutaneous sclerosis, they have higher manifestations of multi-organ presentation, and it can present in earlier of the disease compared to the limited cutaneous systemic sclerosis, where the pulmonary arterial hypertension and GI malabsorption is the later complications. So for those who are actually sitting in rheumatology clinic or probably helping us in the clinic, you probably are more familiar with this, what we call a modified Whitney skin score, which are used to actually assess patients in our clinic for skin manifestation. We also be one of the actually skin score for us to assess the treatment response when we see systemic sclerosis patient in the clinic. So often those patients who have score of more than 25 are considered severe, but the newest research has actually endorsed the score of 15 as the enrollment criteria for severe scleroderma and should be started on treatment faster. How about other subtypes of systemic sclerosis? So we have another one subtype which are called systemic sclerosis in scleroderma. In this group of patients, they tend to present with multiple internal organ manifestation and positivity of autoantibody, but they don't have phenotype of cutaneous changes. So this is probably we might miss out, and maybe you can recently, if you are attending more thorax conference, they might actually tell you about this IPAF, where the patient has lung manifestation and autoantibody positivity, but they might not have a clinical phenotype of scleroderma like what we saw in clinic, like the microstomia, Raynaud's or sclerodactyly itself. So this subtype has been rare in the registry, about 4% of the cohort. And the other subtype is overlap syndrome. So overlap syndrome means that the systemic sclerosis can actually coexist with other autoimmune rheumatic disease. And in the review by the USTAR group, systemic sclerosis can overlap with inflammatory myositis in 11 to 45% of patients. Sjogren's syndrome 10 to 42%. Rheumatoid arthritis and SLE are relatively rare. So systemic sclerosis is known to be a complex disease. Why do we say so? So because at present, it can cause all the clinical manifestation in almost all parts of the body. It can cause digital vasculopathy, it can cause muscle changes or joint inflammation, it can cause lungs fibrosis, it can cause pulmonary arterial hypertension, GI manifestation, as well as renal crisis and cardiac myositis. You might actually able to divide the clinical spectrum of disease based on the presence of the autoantibody. For example, for patients who has anti-centromere positivity, they might actually have clinical association with limited systemic sclerosis or pulmonary arterial hypertension. Those with SCL70 or topoisomerase 1 antibody positive, they often present in patients with diffuse systemic sclerosis and lung fibrosis. And patients who have RNA polymerase III positive should actually be cautious about presentation with renal crisis to the clinic to you. And PMSCL are highly associated with overlap with myositis. So the next part of the presentation will be in classification criteria. So over the year, you know that rheumatology faculty has been improved in the clinical criteria because we actually have more research and more data to show that to give an idea how to diagnose the patient earlier. So the early one is just to distinguish whether this patient is scleroderma or non-scleroderma. But lastly, that the latest classification criteria around us to actually define the disease manifestation based on their pathogenesis itself. Of course, with the advance of technology in the future, we might be able to further subtype the patients and provide the treatment more accurately. So let me introduce on this 2013 ACR or VIOLA criteria. These two are the American College of Rheumatology and European Rheumatology League recommendation of criteria for us to classify or define the patients to have systemic sclerosis when we have score 9 or more. This score has higher sensitivity and specificity. How do they actually classify this patient? They actually give a value score of different manifestations. For example, from the skin manifestations, if the patient has skin tightening, then they have a score of 9. Then you can definitely say this patient is having systemic sclerosis. Then you have to screen the organ and provide the treatment accordingly. In addition to these skin manifestations, the organ manifestation as well as the correlations of autoantibody has been incorporated in this definition criteria. So what is this very early diagnosis of systemic sclerosis or the concept of RADOS? So in Western practice, this RADOS score is actually recommended to the primary care physicians for them to screen for early presentation of systemic sclerosis. So what they recommended is that in any patients that attend to the primary care with Raynaud phenomena, they should be screened for ANA positivity as well as for investigation or physical examination of puffy finger. If they have this clinical presentation as during their attendance to the clinic, they should be referred to the rheumatologist for neuropapillary examination as well as further screening of the specific antibody. If the patient fulfill both of these criteria, they are considered as a RADOS group and they should be recommended for internal organ enlargement screening. So what this concept proof is that in most of the patients who actually fulfill this criteria, in 5 years' time, they subsequently demonstrate full criteria of scleroderma, fulfilling the classification criteria as recommended before. So again, red flag sign of early diagnosis will be the presence of ANA, Raynaud phenomena, puffy fingers, and then they should be referred for capillary to look for active disease of vasculopathy, and then have the serology testing. And in the patient who have ACL70 or anti-synchronial antibody positivity, they should be diagnosed to have very early systemic sclerosis and should be recommended for either esophageal dysmotility study, chest HRCT, pulmonary function test, or to screen for pulmonary arterial hypertension. So come to the differential diagnosis of systemic sclerosis. So different clinical presentations might have have a similar clinical pictures on systemic lupus erythematosus, rheumatoid arthritis, inflammatory myopathy. And then some patients have just visceral presentations, are those with pulmonary arterial hypertension and idiopathic interstitial pulmonary fibrosis. Some of the patients who has colitis might need to be differentiated from systemic sclerosis as well. And of course, I think you might be seeing some of the patients in the clinic with skin tightening, especially in patients with diabetes. Those are not systemic sclerosis and should be excluded. So let me bring you to the review of the morbidity and mortality in systemic sclerosis. So the survival in systemic sclerosis is determined by the subset of organ-based manifestations. These publications has been done by Dr. Denton and his group in Royal Free Hospital, which is one of the research centers in UK. So they demonstrate that in their patient cohort, which was followed up from 1995 to 2003, those patients with diffuse systemic sclerosis has lower survival rate, same as patient with organ involvement in regards to whether you have limited systemic sclerosis or you have diffuse systemic sclerosis. However, the positive of managing patients with systemic sclerosis is that there is the overall improvement of survival over the years. So what is the contributor or what is the factor or the main cause of mortality in systemic sclerosis? And when you look at over the years, you can see that from a couple of years ago, decades ago, renal crises are the main cause of mortality among systemic sclerosis patients. But once treatments has been researched and better algorithm has been recommended, the recent year highest mortality are due to pulmonary arterial hypertension as well as pulmonary fibrosis. So come to renal crisis, let me show you about how the UK scleroderma study group diagnose and manage their patients where they suspect or confirm to have scleroderma renal crisis. They have a diagnostic criteria where the patients presented with high BP of 150 at 85 or the increment of 20 milligrams of systolic blood pressure, and there's evidence of acute kidney injury. Then they support their suspicions with the full blood film show of Maha picture, and then they might actually have a retinal hypertensive retinopathy. They have kidney involvement, and they have renal biopsy to show fibrinoid nephrosis or glomerular shrinkage. And then some of the patients might also have concomitant presence of fresh pulmonary edema. So the recommendations from this UK scleroderma study group is that if the patient has systemic renal scleroderma crisis, they should be considered presentations of medical emergency. So those patients can be nursed in ICU and be treated accordingly, and they should be control their blood pressure aggressively by first-line treatment with ACE inhibitor, followed by ARB, calcium antagonist, and then in UK, they actually start iloprost infusion for this group of patients who has confirmed diagnosis to have a renal crisis. To come back to the ILD as well as PAH as the major cause of mortality in systemic sclerosis. Again, the international guidelines have come up with the algorithm approach to treatment in the patient who have symptomatic after your assessment. They should be started on non-pharmacological management as well as pharmacological management, which include systemic immunosuppression like parenteral steroid as well as immunosuppressant like mycophenolate or cyclophosphamide. But for those who is familiar with this chart, you can actually manage the patient based on the clinical subtype, whether they are inflammatory, where they should be more responsive to immunosuppressant, or they are fibrotic, where you can introduce anti-fibrotic if you have a progressive fibrosing alveolitis. So the newer study has probably recommended rituximab, tocilizumab, IVIG in the group of anti-inflammatory, but not to forget that the anti-fibrotic group now mainly use neutrodimate, which are used in patients with fibrotic type of inflammatory pneumonitis. Come to the systemic sclerosis, pulmonary arterial hypertension. So the study group has actually had a specific screening algorithm that you can look through online. The first one is the DETECT algorithm from the European and UK group from Dr. Coughlin, and the second one is called ACID algorithm, which is the Australia research group themselves. So what they recommended in this scleroderma PAH study is to incorporate the FVC, the LCO, the clinical manifestation, the antibody positivity, and then the organ severity assessment to risk stratify if this patient needed to go for echocardiogram and subsequently right heart catheterization from it. Then looking through on the latest guideline on the ESC 2020 pulmonary hypertension management, we are not having any difference from the treatment like the patient who has idiopathic pulmonary hypertension, which means that we can actually recommend the endothelial receptor antagonist and also phosphodiester 5 inhibitors in the patient who have systemic sclerosis related pulmonary arterial hypertension based on the risk classifications as well as the comorbidity to decide whether the patient should start on monotherapy or should be on combination therapy. And a lot of study also proven, especially in study in a group of PAH where the CTD group of patients had represent almost about 20% in the study population, and the patient in the study group have better outcome. So these are the risk medications has been recommended in ESC guideline for the treatments of pulmonary arterial hypertension. But there is a part of the benefit of immunosuppressant from the recommendation where it should be used in patient with indicated domain like ILD or overlap with SLE itself. So all these guidelines is available online. So the last part of my presentation will be the vasculopathy as a disease burden, and I'll share with you about some of the local experience that we encountered in my center. So digital vasculopathy occur in 95% of systemic sclerosis patients from a mild renal phenomena to severe ischemic digit. It affects the extremities, but also affects other parts of the body like ear, nose itself, and is in response to the environmental temperature changes. Some of them are emotional stressors as well. So you have a classic 5 basic changes of color, where you have the white, which is ischemia, the blue is cyanosis, and the patient outcome that is precipitating factor, they might have a post-ischemic reactive hyperemia, and is often associated with discomfort of pain itself. If those factors are not removed and they continue to have exposure, they might actually subsequently develop digital picking or digit ischemia. So I think this one is familiar to everyone. How do we differentiate the primary from secondary Raynaud's? So secondary Raynaud's often present in older populations. Often is symmetry. It can be asymmetry. It can be episodic with sequential digital ulcer. But in primary Raynaud phenomena, all these organ tissue necrosis shouldn't be present. Bear in mind also, in patients with secondary Raynaud phenomena, they can have abnormal neuropapillary scope examinations, and they can have positive and photoangiometry. And the second part of the digital vasculopathy in systemic sclerosis are digital ulcers. It is the major cause of pain and disability. It happens in about 1/3 of patients who actually have refractory difficult to manage disease. And this digital ulcer actually impact all aspects of the patient personal, social, and family life, including the occupations. And about 10% of the patient can progress to critical ischemia and gangrene itself. So what we conclude that is that the digital ulcer has high impact on health economic burden, either for hospitalizations and medications. So how do the pathophysiology contribute to the vasculopathy in systemic sclerosis? So we have a few factors in the red box where you have vasospasm, you have endothelial dysfunction, intimal fibrosis, you have coagulopathy, and subsequently ended up with ischemic reperfusion injury and tissue fibrosis. So in a lot of study that is also proven to be clinical association of Raynaud phenomena, digital ulcers, and organ manifestation, especially of cardiac manifestation with pulmonary arterial hypertension and diastolic dysfunction. So let me share a case cohort of study done by Dr. Tay in Sarawak, which was year 2009. So in Dr. Tay's cohort at that time, there's 23 patients, and most of them have acute systemic sclerosis. And same as the international cohort, what Dr. Tay found out is that the Raynaud's and digital ulcer is actually high prevalence in the group of patients. So the same finding was found in my center as well. So we actually found that about 40%, about 50% of patients have digital ulcers, and about 80% of patients have Raynaud's melanoma. And I think this year we probably have more than 15 patients have to readmit for either cause infusion. But I'd like to draw attention the difference from local presentation compared to the overseas presentation is that I noticed that in my center, there's a lot of patients who was referred for from the rheumatology colleague for vitiligo or these pigmentations, and with the biopsy, it shows that there is a collagen depositions. So Raynaud's phenomena and digital ulcer is a known burden in the care of systemic sclerosis patients. So I would like to introduce to you the consensus best practice of UK SSG group on the digital respiratory in systemic sclerosis. So how do we manage a patient with Raynaud's phenomena? Once the established diagnosis has been confirmed, we might have to exclude other diagnoses, and then we could pursue the blunt pharmacological measure, which is avoid cold, stop smoking, and this have to be educated to the patient whether they are on the presentation they have Raynaud's or not, because they tend to have aggravated, especially during the cold seasons. If after the non-pharmacological measure, you can proceed with the pharmacological measure, which include the calcium channel blocker, ARB like losartan, you have the SSRI, you have the ACE inhibitor. Some of them actually recommended topical nitrate. Antiplatelet and statin are effective, but it is not all guidelines actually recommended because the data is not very strong itself. If the patient has ineffective oral therapy or refractory disease, IV to stomach or ibuprofen can be considered, and the next step will be the phosphodiesterase 5 inhibitor like sigilafine. Same as digital ulcer, treat the underlying causes. If the patient has wound that is infected, we proceed treating the patient with the antibiotic. If the surgical intervention is needed, please refer to your orthopedic physicians. And then adequate analgesic, because that can actually help to improve the digital ulcer itself. So if it's not useful, you have to consider IV ibuprofen or sildenafil. Some centers actually perform digital sympathectomy, especially in the center with a research team. Last will be the management of critical digital ischemia in systemic sclerosis. I think it's almost the same as previous one. Please quickly admit a patient, treat the underlying contributing factors. You might have to screen for anti-facility in the patient's clinically or laboratories suspicious. And then you start the patient on IV plasma and adequate analgesic, and then subsequently escalate the treatment accordingly. So these are the example of drugs that is used to treat patients with Raynaud's and digital respiratory. You have a calcium channel blocker, which is amphotericin on the victim and the poison itself. You have the angiotensin receptor inhibitor, losartan. You can use fluoxetine. You can consider alpha blocker like trazodone, and then phosphodiesterase 5 inhibitor, including sildenafil and sildenafil, which is already proven in clinical SCLERODERMA cohort that is help to prevent or reduce the frequency of Raynaud's phenomena. So these are the available drugs in Malaysia formulary, and you can see that the indications of Raynaud's phenomena or digital ulcer has never been there. So what we use in my practice is we have to apply through the KPK in patients that is indicated to be treated. So come to my last slide. The take-home message today from my lecture will be: systemic sclerosis is a complex disease with multi-organ involvement, but with better healthcare system, the diagnosis of this complex disease has become less complex. That will include other rheumatic diseases. And the early recognition with the concept of redos allow the screening and treatment of internal organ involvement. That also reflects that the survival in the mortality and morbidity in this group of patients can be reduced. And then vasculopathy is the hallmark of the pathogenesis. It causes high burden of disease and it should be managed attentively. With that, I thank you for listening to the presentation.
Okay. Thank you, Dr. Wong, for the very comprehensive review of scleroderma, which is a very challenging illness. There is a question in the Q&A session from the attendee asking about how does one diagnose scleroderma through pruritus and hypopigmentation.
Right. You know, actually, interestingly, I have a good dermatology team in Johor, which is by Dr. Lata and Dr. Wong or Dr. Tay in HSAJD. So what happened to this group of patients is that when the patient present to GP and complain of these pigmentations, I think the primary care team actually look through whether the patient has Raynaud's, or they actually refer to the skin team for them to manage vitiligo. But what the current practice from the dermatology team is that they actually perform biopsy in all patients, and fortunately, the biopsy sample returned to the collagen depositions, and in the acute setting, not say acute, like very fast, they actually refer to the rheumatology team for antibody screening as well as internal organ examinations.
I think everybody want to diagnose this disease earlier. So how do you advise physician to quickly diagnose this condition?
Right. So I think like a conventional study, you know, rheumatological condition, right, is somehow is a diagnosis of exclusion, right? So you have other etiology that you really have to exclude, but look at the epidemiology as well. So when you look at the differential diagnosis list that I have shared with you, in patient with chronic diabetes, you might have to exclude that they might actually just have a diabetes finger changes, right? In patients who actually have a female, because this disease is more predilection to female, middle age, then you can give a high suspicions on them. Furthermore, in a rheumatology condition, you have to really ask for proper clinical history presentations. So in overseas, the hallmark is Raynaud's. Then you can go through there and probably have a DNA test done. But not forget to check them clinically, check on the skin changes, because they tend to have a skin pigmentation. This pigmentation, especially you can see on the neck area and on the hand area as well. So put on high risk of suspicion, but not to forget as well to exclude those diagnoses, including paraneoplasm and patient with breast implants as well.
There is another question in the Q&A session. Dr. Benjamin Ng raised the question about neurological manifestation of scleroderma.
Right.
And what is the approach? How do you approach the neurological manifestation?
I think that is a complex question, but based on my experience, the scleroderma can present with the mononeuritis multiplex. You know, some of patients who has trigeminal neuralgia and carpal tunnel syndrome can be the early manifestations of systemic sclerosis. So I think in the patients that present to you, right, they definitely, not everyone just have one symptoms, right? As a physician, get a proper history from them. You might able to elicit some of the history that guide you to the way of suspicious and get the antibody test performed.
There is another question regarding diagnosis of pulmonary hypertension. How do you diagnose and manage pulmonary hypertension among the patient with scleroderma?
Right. So I think this one so if you have attend the latest European pulmonary arterial hypertension symposium, is that the classification of pulmonary hypertension, there's 5 classes of it, and you look through patients with systemic sclerosis, they can actually present to almost all the classes of pulmonary arterial hypertension. They can be a CTD, class 1 PAH, they can be having interstitial lung disease, where is the 3rd classifications of PAH. In scleroderma patients, they also have the risk of getting cardiac dysfunction, which is a 2nd group of PAH. And then in part of the scleroderma patient that have a tendency to have renal thromboembolism. So if you screen them and you have a CTPA done, if they have thromboembolism, then it is a 4th group of it. So I think they have different phases of presentations that you have to really investigate properly and probably have an MDT discussion with the cardiac team and ILD. This is what we do in job 4. And then from there, definitely if clinical suspicious and patient is stable with the risk score of PAH is there based on the echo, right? Your tricuspid jet velocity, your anti-centromere antibody positivity, the patient have a telangiectasia, right? So those are good in high suspicious that you might have to really force your cardiologist to have the right heart catheterization done, because the latest PAH treatment has really proven to improve the survival in this group of patients if they tolerate treatment very well.
Thank you, Dr. Wong, for answering all the questions. I think scleroderma is a challenging disease. Currently, there is no cure for this condition. So can you elaborate more on the treatment for this disabling disease?
Right. So I think like what Dr. Tay said, it is a multi-organ manifestation, but there is two groups of patients that I probably sub-classify. The first is the internal organ life patterning manifestation. The other one is the functional outside the skin and the joint manifestation. So how do we investigate is based on how do we treat the patient based on the organ manifestation. So in patient with interstitial lung disease, do consider immunosuppressant. In patient with the renal crisis, just like the flow chart I showed you, ACE is the the leading drug for you to initiate that is proven to actually reverse the pathogenesis in renal crisis. And patient with cardiomyopathy, because the cardiology can actually perform MRI to actually show the signal of inflammation, and then the study has showed that this group of patients you might consider immunosuppressant. And for skin manifestations, it's already proven using cyclophosphamide methotrexate or mycophenolate. It does help to reduce the pathogenesis. Because when you look at the chart that I showed you just now, in regards to different pathway of the systemic sclerosis pathogenesis, it includes the autoimmune disease, antibody formation, vasculopathy, subsequently collagen deposition. I think a lot of studies are looking through all these 3 pathogenesis and actually develop the targeted therapy towards all these organ manifestations.
Thank you, Dr. Wong, for the comprehensive review. Are there any more questions? So I think the take-home message is to diagnose this condition early with a high index of suspicion and refer to the nearest rheumatologist for further management of this complex condition.
Thank you, Dr. Tay, for summarizing the lecture today.
I hope this rheumatology webinar will be helpful to all the physicians, and hopefully all the attendees have learned something about scleroderma.
Thanks, Dr. Tay and Dr. Wong for the presentation. Thank you also to everyone in attendance. So for the following week, on the 15th of December, will be a very interesting topic as well. It will be the autoantibodies in rheumatology and how to interpret them. As we know, autoantibodies are what we call the gateway into rheumatology. So I think it would be very useful for